Good afternoon, everyone. I'm going to continue to monitor the chat, but while we're doing that, please go ahead and make sure your line is muted, but we want to know who you are. So please include your name and affiliation in the chat for us. That'd be greatly appreciated. And I've brought up just kind of our starting orientation slides, which are standard across. Again, want to welcome everyone to our March Grand Rounds, Ability Grand Rounds by the Center for Excellence in Disabilities. The purpose of this series, again, is to share from one another. So we encourage active discussion, whether it's in the chat or raising your hand and engaging without mute. But we're sharing evidence-based research from the local, statewide, national, and many times international platforms. Closed captioning is available. You should be able to find the menu at the Zoom menu bar. Please let me know in chat if you have any questions or you're having issues with that. As I mentioned, we do want to encourage active discussion, but in the meantime, please make sure that you mute your line. Share your name and affiliation as you continue to come into the meeting. Please use your camera if you're comfortable doing so. And then again, raise your hand, chat, go off mute. There will be a point at the end of the conversation, the presentation for questions, and I encourage everyone to do that. So I'm going to stop sharing my screen at this point, and I want to introduce our speakers for the March Grand Round. So first we have Katie Maynard. Katie is a licensed professional counselor. She's a supervisor and advanced alcohol and drug counselor in West Virginia. She specializes in substance use disorder and has worked in the field of counseling since 2010 in several different settings, including residential, detox, outpatient, and medication assisted treatment, or MAT. We also have Alissa Terry. Alissa is a board certified genetic counselor in New York State and has been working with the federally funded New York Mid-Atlantic Caribbean, or NYMAC, you'll see in their backgrounds, Regional Genetics Network for the past 6 years. Currently, Alissa serves as the project manager and telegenetics navigator for NYMAC. She received her bachelor's in biology from Cornell University and her master's in science and genetic counseling from Johns Hopkins University. She's worked in various capacities for the genetic counseling program at the Fair Institute since 2006. Last but not least, Radhika Sawh is a board certified genetic counselor working in New York. She earned a dual bachelor's degree in biology and psychology from Boston College and a master's degree in human genetics from Sarah Lawrence College. Radhika is currently the Continental States team lead for the New York Mid-Atlantic Caribbean Region Genetics Network. Her prior work experiences include clinical genetic counseling at a high-volume prenatal center, employment in the nonprofit sector as the National Director of the Patient Services for the Cooley's Anemia Foundation, and nearly 10 years on the faculty of the Joan H. Marks Graduate Program in Human Genetics at Sarah Lawrence College. With those introductions, I turn it over to Radhika for our presentation today. Thank you so much.
Thank you so much for having us here today. I'm going to share my screen, so just bear with me one moment as I do that. And you're going to see the way too many things on my screen, so just bear with me 1 second. All right. And Alissa is going to start us off. So once I start sharing, hopefully she can do that. Okay, Alissa.
Right. I'm seeing your presenter view, Radhika.
Oh, my apologies. Hold on 1 second. Of course, it did the wrong one. Is that
There you
better?
go. Perfect.
Okay.
Great. All right. We're so excited to be with all of you today. We're going to talk a little bit today about genetics and health and just why it matters in the world of the kind of work that all of you do. So we really appreciate your time today. We've already had introductions. Here's the three of us. You'll hear from us one at a time throughout the series, and we're all open to questions, as was mentioned, at any time using the chat or raising your hand. Happy to answer. So NYMAC was mentioned before. NYMAC is one of 7 regional genetics networks supported by a federal grant from the Health Resources and Service Administration's Maternal Child Health Bureau. And the focus of our work is to improve access to genetic services within our jurisdiction, which is the little colored piece you can see popped out of the map there. And it includes, of course, West Virginia. So we have a local team of stakeholders from West Virginia that have met regularly over the past couple years to address barriers in genetic services in your state. In West Virginia, the number of genetics providers, both genetic counselors and clinical physician geneticists, are far below the recommended amount based on the population. And due to that limited number of specialists, the West Virginia team has really focused their efforts on educating providers about genetics. So today we're going to talk about what families could really benefit from genetics and really understanding how to best utilize these specialists. Really in West Virginia, the only place to get genetic services is at WVU Medicine. They've been a really close partner with us over the past few years in understanding the strengths and limitations of genetics in the state. So they do pediatric genetic services, and we have the contact information there. They also do services around maternal fetal medicine and also for cancer genetics. This information is also on their website and on our website as well, which we'll give as a resource at the end, but we just wanted to kind of touch base about what's really happening in West Virginia. So on the next slide, we do know that there's a lot of reasons that people either don't seek out genetic services or maybe are even a little wary of talking about genetics at all, and we acknowledge that. Some people think that all genetics appointments involve genetic testing, and we want people to know that that's not true. A genetic specialist might offer testing only if it's medically appropriate, and then the patient or family always has the right to decline. We're going to talk about this again later in the presentation. Sometimes people are fearful that if they do genetic testing, that their personal information might be stored in a database or used for other purposes or can be made public. Thankfully, there are some laws in place to safeguard people's information. Sometimes people shy away from genetics because of concerns like stigma, discrimination, isolation from their community because of having some sort of undesirable condition. This can often cause a lowering of kind of status within the community. There are health disparities in genetics, just like in a lot of other areas of healthcare, where there's unequal treatment of patients on the basis of their socioeconomic status, sometimes gender, or that really causes increased barriers for those underserved communities to connect with genetics. And finally, like we were just talking about in West Virginia, due to the limited number of genetic specialists, families are often faced with really long wait times to try to get an appointment, or a very long drive to try to get there. So those are big things that also create barriers. On the next slide, we're curious if you in the audience have some thoughts of medical issues that you see in your work or in your everyday life that you think are genetic. So are there any medical things that you can imagine and share in the chat that you typically think of might be genetic? You can put ideas that you might have in the chat. Okay. Not seeing anything yet. Some of the examples people often give, yes. Okay, perfect. So we're seeing ALS, Parkinson's, diabetes, Huntington's disease for sure. Hemophilia, absolutely. Great examples. Almost everything. That's a good answer. We do think that a lot of medical conditions have some genetic components. Some of them are really entirely caused by genetics, like Down syndrome that someone just mentioned. Other ones have kind of a genetic component for some families and not for others. So those are great examples. So some of the things that we often talk with people about or we hear about are autism. A lot of forms of autism are genetic. Developmental delay or intellectual disability, hearing challenges in young people, as well as vision challenges, blood disorders, as someone mentioned, including hemophilias, but other anemias and blood clotting issues, cancers. So a lot of cancers that we see in children or in adults can be genetic, as well as heart issues. So those are really medical issues that touch all of us. Most people probably have members of their family or friends that have these conditions. So genetics is kind of everywhere, which is what somebody said. So on the next slide, sometimes it's really helpful for people to just think about what this means in numbers. So what we know right now is that for autism, about 25% of cases have a genetic component. In hearing loss in babies, about 50 to 60% are genetic, and about 10% of cancers. One of the biggest issues is that many families have no idea that they have a genetic condition or that their family's at risk for one. So that's a big issue across the United States and other places. On the next slide, people often think as well about rare disease. So at this point, there's an estimation that there's about 7,000 rare diseases, and about 80% of those have a genetic cause, and about 50 to 75% affect children. So rare diseases as a whole, big group, are not that rare. Like when you think about all of them all together, it's actually pretty common for a family or friend group to have rare disease. And a lot of those are genetic conditions. And NORD is a great organization, and they remind us often of that concept that rare disease are individually rare, but when you put them all together, they are collectively common. NORD's a great resource for rare disease. All right, so on the next slide, I'm going to ask you now a slightly different question. You shared with me in chat some medical issues that you know are genetic, but what are some of the terms, the vocabulary, the words that you think about when we say genetics? What comes to mind for you? Kind of the lingo that you know that people use around genetics. DNA, absolutely. Hereditary. mRNA. Ooh, Leslie, nice. I don't think we're going to get to mRNA today, but recessive, absolutely. Great. And you can see in this image on the screen, chromosome, somebody put some of the other words that other people come up with. Some of them mirror the ones that you guys have shared, DNA being kind of a big one that we see there, autosomal dominant, someone just shared. So what we're going to do now is sort of go through an example, an exercise that we do with a lot of families, but we also do it with a lot of professionals, community health workers, early intervention professionals, even physicians, to help them really simplify some of these complex words that either they need to use themselves or that they need to talk with families about. So on the next slide, to help us really think about some of the most common and useful terms you might hear, we're going to talk through a cooking analogy. And that's going to help you see how DNA, genes, chromosomes, and genomes relate to each other, and how changes in the DNA can result in health challenges. So we're going to go through a bunch of slides, and we're going to come back to this picture at the end. And these handouts are also available for download. So if it's something you see that might be useful to you, you can download these. Okay, so on the next slide, DNA was the first word that came up, I think, in the chat. So DNA stands for deoxyribonucleic acid, which you do not need to know. But basically, DNA is the alphabet that we use to write the instructions that tell our body how to grow and function. Instead of using the whole alphabet, our body just uses these 4 letters, A, T, C, and G. So you can really just think about those as the letters we're going to use to write a recipe. On the next slide, most of you have probably heard of genes. So genes are just a section of the DNA that contain instructions or a recipe to make something that the body needs. You can see at the bottom here that you think of a gene like a single recipe for something. For most, but not all of the genes that humans have, we have 2 copies of it, one from our biological mother and one from our biological father. Just like you might get passed down a cookie recipe from both your mom and your dad's family. And those 2 cookie recipes might be identical. They might be really similar, or they might be pretty different. Same thing stands for our genes and the way we get them from mom and dad. On the next slide, another word that came up in the chat was chromosome. So a chromosome is really like a recipe book. So a collection of DNA, and each chromosome has many genes, just like a recipe book has many recipes. So in human cells, like our skin cells, hair cells, heart cells, we usually have 46 chromosomes, which are in 23 pairs. As I said, one from your mom, one from your dad. The chromosomes are numbered 1 to 22, and that 23rd pair are what we call the sex chromosomes, and we label those X and Y. One very common genetic condition that people have heard of and was mentioned in the chat as well is Down syndrome, which is when there are 3 copies of chromosome number 21 in the cells instead of 2 copies. But there are many other ways that a person can have differences in their chromosomes as well, whether it's extra or missing chromosomes, pieces of the chromosomes that are missing or duplicated or rearranged. If you think again about that set of recipe books, it would be like looking to see if anyone was missing or had an extra one of their 46 books, or if the books are missing sections or have extra sections. So I also want to note here that there is some DNA in our cells that's not part of these 46 chromosomes. It is instead in our mitochondria, and that is only comes from the mother. So it's just one little caveat to the rule. Okay, on the next slide, the word genome comes up a lot. A lot of people bring that word forward. The genome is really just the entire set of genetic instructions found in the body. So it's all that information that's contained in that full set of 46 recipe books, plus the DNA in our mitochondria from our mother. Okay, on the next slide, as I mentioned, we're sort of coming back to that picture that we started with. So the A, T, C, and G of the DNA is just the alphabet that we use to write out the recipes. One gene is like a single recipe. One chromosome is like a book that contains a bunch of recipes. The genome is the full set of 47 recipe books. And the whole point of all these recipes is to tell our body how to make something we really need. That's the goal of the recipe, just like you might have a recipe for cake. So while we're thinking about those types of recipes, the next thing that is important to consider is how changes in our genes can lead to health challenges and disability. So here we want to first remind people that genes themselves do not cause disease. So genetic conditions are caused by changes that alter a gene's function. So for example, when someone says that they have the cystic fibrosis gene, they are really referring to a version of that gene that contains a variant in the DNA or the recipe that makes the protein come out differently. And then that protein can't perform its typical function in the body, and the person has health challenges. But all people, including those without cystic fibrosis, do have the cystic fibrosis gene. It's just whether or not there's a change in it. And on the next slide, we also think it's important to remember that not all genetic changes do cause health challenges. So sometimes they have no impact at all. Sometimes they can just have a very minor change in the way a person looks. Sometimes they can even be advantageous. But there are some genetic changes that cause the form or function of a product that the body really needs to change or not be there. And those changes are referred to using different terms. I think somebody put in the chat the word mutation earlier. More often now you'll hear people talk about different types of genetic variants. So again, these variations can cause no change, can create good change, or can create small or large health challenges for the body. All right, so on the next slide, we're going to think back again about our recipes. And I want you to think about a time where you have asked somebody else for a recipe. So you went to somebody's house, maybe it was a family member, maybe a friend, and they served something great and you asked them for the recipe. And so sometimes we will get a pen and write that out by hand, or maybe we'll type it out. I know most of the time we take pictures now, but imagine that we're going to write it out by hand or we're going to type it. So sometimes when we do that, there could be a little typo that we make when we're copying it over, just something changed from the original. So that same thing happens when we copy our DNA, and our body really needs to copy our DNA all the time. So if we change something in the DNA or the recipe, it can change what we get as the final product. Like here, you can see that the recipe changed and called for cheese instead of cocoa. So the outcome is cheesecake instead of chocolate cake. But these are both great outcomes. Not one is worse than the other. They just are different because the recipe was different. I'm curious if anyone can think of a genetic change that we see in people that causes people to have a minor difference like this. Like some people have chocolate cake, some people have cheesecake. Can anyone think of something that you can observe in other people along those lines where there's some genetic change that makes people a little bit different in some way that we can see. Hair and eye color, perfect. That's the one. I'm sure there are others, but that's the most common one that we think about. You know, there is a change in the DNA. It makes people different. Long second toe. Yes, I've been hearing about that one. So very similar to that type of thing. On the next slide, it's important to keep in mind that when a genetic change is happening inside the body and something that the body needs isn't produced in a high enough amount or has a different shape or format, sometimes these differences in quantity or function will appear as signs or symptoms in the person's body. And genetic conditions can truly impact any part of the body, depending on what the change is and where that product is needed. These differences might be observable as early on as pregnancy ultrasounds, or may not show up until very old age. But as you can see, the little boy on the right, it really can happen, signs and symptoms, pretty much anywhere in the body, depending on the particular diagnosis. All right, on the next slide, when I asked you in the beginning, people had put in the chat ideas about recessive and dominant. We just use this slide to let people know that things can run in families in a variety of different ways. There are many different ways that genetic changes can be passed through families or can even happen in a family for the very first time. So sometimes you can see parents and children with the same genetic condition. And that's what this little figure with the purple and gray is showing. The father has a medical condition that's genetic. He passed it on to some of his kids. They have the same types of signs and symptoms. But then sometimes we see families where multiple siblings have a condition that the parents don't have. That happens with recessive conditions, which someone mentioned. Sometimes only the boys in a family will have a condition, or sometimes only the girls. Sometimes it's only passed down by the mom. And sometimes a genetic change happens for the very first time in one person, and they may or may not be able to pass that on. So that tells us that not all genetic conditions are inherited. Sometimes mom and dad don't have it. It happens when we're copying DNA to make those sperm and egg cells. And so it happens in the very first time in their child. So we definitely don't expect you to commit all of these to memory. We simply think it's important to know there are different ways that genetic issues, conditions can run through families or appear in that family tree for the very first time. And one of the reasons that we're talking with all of you today is because we know that in your varied and diverse roles that you have throughout West Virginia, you might be positioned to notice some of these signs or symptoms in the kids and the families you work with, which is kind of leaving you in kind of a detector position. And that also means you might be uniquely positioned to help a family advocate for a genetics referral if they need one, since you might have more frequent contact with the family than other medical providers do. So really help people and families make those connections. So I appreciate your time. With all of that information, I'm going to now introduce Katie, who is going to tell a much more interesting and real story about her very own family. We're so grateful that Katie's here to share that with us. Katie, you're muted.
Can you all hear me?
Yes.
Yes, we can hear you now.
Okay, I'm like doing it on my computer and phone. I'm having super IT issues today. So I was like unmuted on my phone, but I had to unmute on my computer. Okay, so we've got it. And now I've learned something. Yes, I am Katie Maynard. I am the mom to Judson Maverick Maynard. He was born November 12th in 2019 and lived just a little over 10 months and passed away in September 20th, 2020. And so I was asked as a member of the NYMAC, as a volunteer, to kind of share with you all my experience in having a child with a genetic disorder, which we will kind of talk about on this journey. So I'm going to go ahead to the next slide, please. Okay, so I want to kind of take you all along this journey with me, and I want to backdate even before I discuss this prenatal experience to talk that I did have my first son was born in 2015, and he would have been a child that we almost would have anticipated having a genetic disorder because I was pregnant with him and had a 2-vessel cord. So I had very intense monitoring the second half of my pregnancy, but had a completely normal child. So fast forward a few more years, I was pregnant with Judson. In March of 2019, learned pretty early that I was pregnant. In May, which this was something new, the Panorama genetic screening was available, and we did opt to do that because I wanted to know what my baby was, if it was a boy or a girl, so early on. And so that detects some basic chromosomal abnormalities, and that scan came back completely normal. We did learn at that time that my son was a boy, so we were excited to have 2 boys. June 2019, I would have had a normal 20-week scan. There was no issues, no concerns. He was growing. You can see in this picture, this is one of his ultrasound scans. He was growing as they anticipated. Everything was measuring fine. November 11th, and I want to say November 15th, which is actually my birthday, was my due date for him. But by November 11th, my doctor felt that I probably could be induced because I was on my feet all the time working. So November 11th, they induced him early in the morning. And then by November 12th at 1:30 in the morning, very early in the morning, Judson Maverick Maynard was born. We can go ahead to the next slide. So this is where our journey took a big kind of left turn. You see there, that is a picture of him immediately after I had him. So during, I delivered him and had a pretty normal delivery for the most part. He was kind of slow to come, but then when he made his big entrance, he sure made it. So during the nursing examination, he was very floppy and had no startle response. So when they would pick up, I have a video kind of where they would pick up his arms, and when they would let him go, a baby should kind of shake and hold him kind of stiff, and he did not do that. His arms would just fall flat, kind of like a noodle. And then he was also low respiration, so not breathing very strong. At that time, they were quick to call, and I delivered him at Hoops Children's Hospital in Huntington, part of Cabell. They were quick to call at that time the NICU, Dr. Loudon, consulted with him, and he quickly recommended a skin-to-skin contact to, and the term they used was to see if he would just kind of wake up. So we gave him, got to hold him for a few minutes. Mother and baby nurse came in at that time and did another evaluation, took him, did another evaluation. He continued to be floppy, no startle response. And then the big, I would say his one-way ticket to the NICU was a blood sugar of 16 degrees, or 16 degrees. Blood sugar was a 16, and for a newborn, it should be above 55. And so this got his one-way trip to the NICU at that time. So we can go ahead to the next slide. So it was a very quick 24 hours. You know, there was a lot happening in the first 24 hours of his life. This is a picture within 24 hours. So you can kind of see just even from that previous picture to this one, how much has changed. 24 hours, he was placed on a CPAP. Now in this image, he's just on a nose cannula, but initially he was on a CPAP. They did an NG tube for feedings. They did notice something unique for him was he had misshapen ears. It almost looked like they had all crumbled up and folded inside. And the NICU nursing team identified pretty early on a repetitive eye movement. So just a slight jerk, similar to a nystagmus, but it was more pronounced and it was very repetitive. So that is what immediately called in a neurological consult. And you can see on this one, he actually has his EEG started, and they started a phenobarbital dose to keep his seizures hopefully at bay at this point. So we can go ahead to the next slide. So there was not much known at this time. Neonatologists had no answers or ideas of what was causing the issue. There was a lot of questioning. Of course, if you're familiar with the Huntington area, there is a high rate of substance use in babies born with neonatal accident syndrome. And ironically, I work in that field, but I'm not an individual in recovery. And so I was questioned a lot about that. So they had a lot of questions with no answers. Seizures became more managed, but kept him very sedated. So he did have to maintain being on oxygen. And there was a belief that since there was a belief that we could take him off of the seizure medications, that he would be able to breathe on his own. But if we took him off the seizure medications, then he was going to have to the balance there. So then there was, the first, or I want to kind of call it the low-hanging fruit, was do a chromosome testing. So they did his chromosome testing within first 2 to 3 days of him being alive. There was no significant variance noted. I want to say he has not a deletion, but an addition on a certain chromosome. And the chromosome testing that was done for our family was enabled both me and my husband to have ours as well, just to give a complete picture. And my husband also had the same additional chromosome. So that really didn't answer any of our questions. So day 12 came, and a NICU resident just kind of was putting puzzle pieces together. And at that time, we had Dr. Hummel in the state, and Dr. Hummel happened to be at Cabell Huntington Hospital in the pediatrics doing monthly rotations, a monthly clinic at the Marshall Peds. So they said, why don't we call her and have her come up when she has a break to do an evaluation? So that's what we did. Go ahead to the next slide. Okay, so then Dr. Hummel, and the picture on the other one was the first day I got to hold him. He was 3 days old. This is probably about day 12 that Dr. Hummel did an evaluation. And some of the things she noted was that his eyes were wider and more spread apart. His ears were lower and small ear canals, and to the point that in the one ear, they weren't sure if the ear canal actually completely opened and created. He also had wider set nipples and a very flat nasal or nose bridge. She did the parental interview. At that time, it was just myself. My husband was back at work, just to balance the home and hospital life. And I do always take this time to joke and laugh, but her first question was if we were related. And my husband is from Wayne County, West Virginia, and I am from Baltimore, so Maryland. So we know we are not related really now because of genetic testing. She did go back and staff with the NICU, and the first thing she said was, I'm ordering a very long chain fatty acid test. Call me when you get the results. And so that's what they did. And during that time, we kind of waited. We can go ahead to the next slide. And this is our life in the NICU. He graduated to a regular pediatric crib because we joked he was probably the largest baby in the NICU. They're very used to very tiny babies. And so we graduated. He continued to have EEGs on and off. And if you do kind of notice in some of these pictures, he has things on his ears because at that time, we were not really sure of his prognosis. And so there was some things they could do to try to stretch out and make his ears appear more normal and more functional. So they were doing that. It was a mold placed over his ears. And we can go to the next slide. So at 22 days old was kind of, I would say, where our life changed. So at 22 days old, we were called by the nursing staff and requested that we both be present for the rounds. They kind of knew that I did the day shift and my husband did the evening shift, so that we would be visited by the neonatologist, and that we were scheduled to be his last patient because he did want to discuss his diagnosis. So Dr. Werkhammer, which if anybody is familiar with Cabell and Hoops Children's Hospital and NICU, he, I think, laid the first cornerstone to Hoops Children's Hospital. He gave us our diagnosis of Zellweger spectrum disorder, which is a paroxysmal biogenesis disorder, more specifically known Zellweger spectrum disorder, which is a terminal diagnosis based off his presenting condition at that time. I won't get in on much about what paroxysmal biogenesis is disorder, but PBD, about 1 in 50,000 births are affected by PBD in North America, which is approximately 80 a year. And really what it just means is that one of your peroxisomes does not have all the complete directions to work properly. And so they are absent or severely decreased. And so they are not working properly. So that was the diagnosis that we were looking at. Go ahead to the next slide. So it was a very busy time at 22 days old. That was right before Christmas, if you guys are kind of trying to think what time of year it was. They quickly, once we got that diagnosis and the very long chain fatty acid test back, consultations quickly happened with Cincinnati Children's Hospital, who had done some research on a medication called Cholbam, and Johns Hopkins, which had worked had done some stuff early on in some research labs, and one of the leading doctors to see most babies with paroxysmal disorders works out of Johns Hopkins. So we were able to consult with those individuals. Interesting enough, and I work in the medical field, so I kind of know how things work in the normal, but a drug rep came and spoke to me first from Retrophin, talking about Cholbam, which is a cholic acid medication to help the body down regulate in the liver functioning. And so they came and talked to me first before they even talked to a doctor, before they even went to my pediatrician. They even drove across town to the pediatrician. Then we were offered, because we did use the Cholbam medication, Retrophin paid for our genetic testing to identify our genes. He also then went G-tube surgery. One of the early recommendations from Johns Hopkins was to do a G-tube surgery as early as possible, that no one should have to fight for their food. And if we knew his muscle tone was most likely not going to improve. And so we did a G-tube surgery, and we were discharged just in time for Christmas. And one of the most important things I think that happened also during that time is that we were linked to an organization called the Global Foundation for Paroxysmal Disorders. And that organization champions for families across the board. And we were provided a current research or treatment recommendation protocol for our children. Next slide. So kind of what did Zellweger spectrum disorder look like for us? Some of the key things is most likely what we know, Judson was deaf and blind. So he did have a hearing aid. We don't really know how much. We never got to do a sedated hearing test to know exactly how much he could hear. Low to no muscle tone. So he couldn't hold things, couldn't hold his head up, couldn't hold his arms up. I would say he was unable to make those normal baby cooing sounds, crying. I don't really recall any in his 10 months hearing a cry from him. And I do recall maybe once or twice getting a laugh from him. So he was unable to take oral feeds. And 2 of these photos, you can see him getting his breakfast or lunch through his G-tube. There were multiple doses of medication several times a day, including 2 seizure medications and a rescue med as needed. Vitamins, he would take his A, D, E, and K vitamins mixed in his food, just a variety of different things to help improve his daily functioning and truly to manage his seizures, because there is not a cure. And they did a great job sharing about the rare diseases, and for most of those, like 95% of the rare diseases, we don't have effective treatments for. They just treat symptoms, but not treating root causes or dialing down from that. And Zellweger spectrum is one of those as well. So he was at 8 months old, became oxygen dependent. After a second hospital stay, he was on oxygen 24/7. So that just kind of led to, more complication. And I think it was muscle tone as he got bigger, because he was over 20 pounds when he passed away. As he got bigger, it was harder for him to breathe. And then one of his big presenting issues is he also had kidney stones. And I saved you all from looking at that of a picture of what is kidney stones, but imagine finding sand in a diaper was very much the granular feeling of his kidney stones. We can go to the next slide. I think this is really important when we do talk about rare diseases and kind of all hands on deck, what impact it had. We did have a multidisciplinary team, and that was both medical as well as supportive services like speech, physical therapy, occupational therapy, and a vision specialist. And I do think that's really important because although his diagnosis said he was going to live past 6 months, is what they usually or used to tell people, we refused to have that be the end all be all. We did not know how long Judson was going to live. And so we wanted to throw everything at it to give the best quality of life. We were linked to Braverman Labs in Canada. Dr. Braverman does PEX1 models on rats. And so we were able to do a family history with her. We were linked with Dr. Gerald Raymond at Johns Hopkins. We were able to visit him in the height of COVID, which was really exciting. Despite insurances denying our visit, he was very adamant that he was going to see us regardless of what his office said insurance would or would not pay. And then we were also able to become involved with the Global Foundation for Peroxisoma Disorders, where we are now currently participating in a natural history study where they're just taking all of our data and combining it. Family support and medical profession consultation. We do have a handful of medical professionals across the globe that do research PBD, ZSD, and are available for consult for families like ours. Go ahead, next slide. And so that is, I think, the end of my section.
It is.
And I will pass it on. Okay.
Thank you. Thank you so much, Katie. Your story is really powerful and heartbreaking, and we are really appreciative that you're willing to share your son with us and your time with him. So thank you so much for being here with us.
Absolutely. And I will drop my email in the chat box if there's any questions or anything. Anybody, feel free to email me. I'm in this realm an open book, so I don't mind to share information.
We really appreciate that. Thank you, Katie. So,
Thank you.
Katie's story actually started right after birth with her son. As she told you, everything, during the prenatal period, there really wasn't any signs, but, and that just goes, that can happen. And what I want to talk about now is some signs and symptoms and clues that there could be a genetic condition happening either in a specific person or in the family, and that these can actually happen anytime during the lifespan. So I'm going to start off with during the prenatal period or the newborn period. So Katie's story began in the newborn period, but it actually can happen prenatally. And sometimes those prenatal concerns can include like an unusual finding during a routine ultrasound, which for those of you who, had families or been pregnant, you can, you appreciate that there are certain times during the pregnancy that they do what's called an anatomy scan. So sometimes during then something can be seen that can, be concerning, and that could lead to down the line of genetic diagnosis. Sometimes screening blood work can come back out of the expected range. Katie talked about that panorama test. And sometimes that does come back saying that, oh no, actually you're at higher risk for something. So that can happen. We can also have either partner who maybe have a child already or a family member with a medical issue that is known or suspected to be genetic, or they've been told already they have a higher chance to have a child with a health issue, or they may believe that the genetic medical issues, excuse me, in their family have a genetic cause. So those are all reasons why, during the prenatal period, we may be concerned about a genetic condition. And then during the newborn period, Katie talked to you about Judson having unexplained medical challenges, and that is often a time when genetics is called. When a child ends up in the NICU and we don't know what is going on, as she was saying, they couldn't explain what was happening. That would be a time that genetics is often called, and you could see how it helped in Judson's situation to actually find that diagnosis, the reason for his symptoms. But it can also be that a baby has a newborn screening blood test, hearing test, or cardiac test whose results are outside the unexpected range. So and that baby could, by all appearances, seem and look normal, but then the blood test shows something else. Oftentimes it's during early childhood, though, that we start to see signs that can indicate a genetic condition may be present, especially because it's during those early childhood years, the developmental years, that we see, maybe a child isn't reaching their milestones. And we all understand that, not everybody walks at the same time, not everybody talks at the same time, but there's an expected range when it should happen. So when it doesn't happen within that range and it's incredibly delayed, then we start to worry. So that can have to do with speech, learning, development, movement, growth, or even digestive or feeding issues. Those are all things that we expect there to be curves and growth curves, and we expect milestones to be hit. And when they're not, that can kind of be what we call a red flag, or something that concerns us, that say, is there some genetic reason why this isn't happening? And Alissa had mentioned earlier that, autism or those types of behaviors could indicate there may be a genetic condition. Children who have early signs of vision loss or hearing loss, or who are born with heart defects or are complicated medical issues such as Judson, are all those who should probably be seen by genetics. We like to say that if a child is being seen by multiple specialists, that's definitely an indication that genetics should be called. But you can also see that within a family that there seems to be issues that we say are running through the family, so that several generations can say have the same type of cancer, or maybe there's unexplained sudden death, kidney disease, or diabetes that happen without those typical risk factors that we think about, epilepsy, or severe vision problems, or severe hearing loss that happens earlier, certain movement disorders such as, we think of Parkinson's, or anemia such as sickle cell disease, thalassemia, certain types of unusual childhood conditions. I already mentioned epilepsy as being one of them. Or, when there's complicated medical issues, and these happen in either multiple generations or in numerous times within a single generation. Those are all signs that, maybe there's a common change in a gene that's being passed down, and that we should look and see if that's, explore that further, because that can have implications for family planning. So generally, what we like to say is there's a rule of 2 and 2. So what we're looking for are extremes, someone who's too tall. And when I say, we understand there's height differences, but you don't expect to see a 5-year-old that's 5 feet tall. Similarly, you don't expect to see a 10-year-old that's only, 3 feet tall. So again, those extremes. When we think about too early, we think about a girl who's maybe hitting puberty at 7, all right? Or someone who's born with multiple birth defects, or, or who just really is very different from the rest of their family, maybe in terms of physical appearance or behaviors. There's something that just doesn't seem right. And in terms of the word 2, it could be a person that's affected with 2 different tumors, 2 different cancers, or 2 generations that are affected with the same thing, or 2 people in the same generation, the same family that have the same issue, or as I said before, 2 or more birth defects. But what we want to remind everybody is that while every person with genetic conditions tend to have multiple red flags, every person with a singular red flag or even two does not have a genetic condition. So these red flags or those symptoms we talked about, those differences, are just simply a clue that there may be a genetic issue happening. And the more we see, the more likely we are concerned. If we see one or two, that can just be like Alissa said, a variation. But when there's several, then we start to worry. So in talking about this, we talked about, why you might be referred to genetics. So I just wanted to ask you, and I promise we're almost done because I want to have time for questions, why you think a family might want to go to genetics. What do you think they might get out of that appointment or looking to get out? Feel free to use the chat if you want to give me any thoughts on what you think, why you might want to seek a genetics appointment. And I know a few of you have actually gone to genetics, so you feel free to share it. But as we're thinking about it, I'm going to share with you, oh, yes, a reassurance of what they might already expect to be a possible diagnosis. Exactly. Sometimes people already have a feeling. They're like, I think I know where this is going, but I really want to hear it from a professional. That's a great one. Thank you, Casey. So I'm going to share with you, just in an interest of time, some of the common reasons we hear. So it could be to follow up, as we just said, about a symptom that concerns them, or a follow-up on a symptom that concerns their primary care provider. It could be to find connections, as we said, about symptoms that may on the surface seem unrelated, but you kind of are wondering, is there something going on here? It could be to understand if patterns of symptoms among family members might be related. Could be to follow up when you have a child that seems to be developing and hitting those milestones, and then suddenly they regress, and then they lose the ability to walk or talk or even hold up their head. That's what we call regression. And when that happens and there's no pinpointable cause, then we start to be concerned that it could have a genetic cause. Could be to find support. So maybe you have a diagnosis and you want to connect with other folks with it. It could be to discuss a known genetic condition in the family. Say you already know, say you have a family history of, say, cystic fibrosis. It's your cousin has it, and you're like, well, what is my chances of having it, or my child's chances? Or it can be, as you said, once a diagnosis is made, to try to help find treatment options and clinical trials and opportunities. So a lot can happen from a genetics appointment. And just really briefly, for those who have never been or are curious, when you go to a genetics appointment, the patient will often meet with a genetic counselor, and they'll be asked detailed questions about their family history or their child's developmental or medical history. Sometimes a geneticist will join the session and do a physical exam that particularly happens in a pediatric setting, so they can help provide an assessment, and they may take measurements and possibly photos. And only if appropriate, the patient may be offered genetic testing. And every session will be slightly different based on the reason for referral. I apologize, I can't see everybody, but Leslie said that there's a question. Teresa, did you want to feel free to unmute yourself?
Yeah, I'm double dutying. I'm driving to a client appointment at the same time that I'm listening to you. But one of the reasons that I think that people would find genetic, would want to get some genetic counseling or testing, would be to, like you said at the very last one, to, out of all of these treatment options for this symptom, which one's going to be best? Which one's going to have the less chance of side effects and the best chance of increasing quality of life?
Exactly. Yeah. So, there definitely, if there are different treatment options, we will talk about the benefits and risks of it. Our whole goal with genetics is always to make families informed and have them make the choice that's best for them. And that can be in regards to treatment options. And as I'm going to be discussing in my next slide, that has to do with also genetic testing, because that's a big concern people have, that if they go to genetic counseling, like, am I going to have to do genetic testing? And in the same way, what Teresa, you just said, we want to inform people. We want them to know what to do, what's best for them. And so we will offer them genetic tests if it's applicable based on their personal, medical, and family history, and always discuss the benefits and risks and explain how the results may affect the patient and their family. Similarly, we could do that with treatment options as well and explain how they will affect both the patient and the family. And we always work, genetic specialists always work with the patients and their families so that they can make the decision that's right for them. It is all about education and empowerment. So just as I just want to finish this off so we can have some time to talk. So what can you do if you think a family might benefit from a genetics referral? Simply, we want to use that medical home model of care. So it's always important that we encourage them to start a conversation with their primary care provider. From there, a detailed family history can be taken and the decision can be made to whether or not they should immediately refer to genetics, right? The primary care can work with the family to decide that. And we encourage you to encourage families to share their concerns with their pediatrician or primary care provider and have conversations about whether there may be a possible genetic cause for the symptoms that they see. And there may be some unique situations where a family might reach out to a genetics clinic directly to try to make an appointment. And some genetics clinics may accept this type of self-referral, but more often than not, they do require a referral from their local doctors. So we want to get the doctors involved. So we encourage you to help empower families to talk to their primary care providers and advocate for a genetic referral by reminding them that they're the expert on their family. And while the provider may have the medical knowledge and the scientific knowledge, they have the personal history and the day-to-day experiences to truly assess if concerns need to be addressed. And you can also, give them tools to advocate for themselves. So you can even say to them, I notice you or your child has seen several specialists, like I referred to before. Has anyone ever talked to you about a genetics referral? Or have you ever told your doctors that there are several people in your family that have that same symptoms as either you or your child? And when you're talking to a primary care provider, it can feel daunting, but you can do it by helping the family prioritize their top 3 concerns, bring data about their concerns, meaning maybe taking a journal and making notes about what they're seeing, when they're seeing, how often they're seeing it. Bring someone trusted with you to the appointment so you feel, more confident. If there wasn't enough time during the appointment to talk about it, schedule a follow-up. And if you're not a native English speaker, ask for an interpreter, because you should be able to speak in your native language and an interpreter should be there to help explain your concerns. And those conversations can be started by simply saying to the primary care, I am concerned about, or my concern about X from our last visit has not resolved. What can be done to explore it further? Or in talking to my family, I learned we have a history of X. Is it possible my concern of this is genetic? So we are happy to say that we have lots of resources on our NYMAC website, which is nymacgenetics.org. And we also have several other resources that I'm happy to share here, such as the CDC Learn the Science Act Early. There's pediatric red flags for genetics on our website. So all of these you can access through our webpage. And also, if you enjoyed this and you want more information about genetics, we have our upcoming free virtual conference that we encourage you to join. It's for families, doctors, advocates, healthcare providers. It's a great way to learn more. So with that, I'm going to stop sharing my screen and just take any questions that they may have. So thank you so much.
Thank you all very much. That was great. So please make sure if you're trying to either raise your hand or go ahead and unmute yourself. While people are doing that, let me ask you, and you may get this all the time. So we're inundated with more and more like 23andMe and that sort. And I know people often go to those resources to find out what they might be susceptible health-wise, because there's so many health profiles. What would you say to someone about those kinds of things? And obviously there are natural differences between what you're today and those, but can you kind of link those two for us?
So I think 23andMe, unfortunately, it's very limited in terms of what it's looking for. I would say it's like the low-hanging fruits. right? It's not going to do a deep dive, and it's not personal to you because they use the same panel, the same test for everybody. So if you have a family history of, say, a seizures, we would rather test you for those genes that we know are associated with seizure disorders. And that's why you go to genetics, because then we will find the testing that's best suited for your situation. It's personalized testing. 23andMe, I'm not saying there aren't some benefits to it, but it's just very broad. And it's looking for the most common gene changes and only a certain number of them. So if you say, well, I did 23andMe, I'm negative, I didn't have any gene changes. Okay, but they only looked at, say, 50 possible ones. There can be there's hundreds of thousands of genes we have. So you really didn't do a comprehensive job. So
Okay.
that's why it's really important. And it's not diagnostic. Those are just there to kind of be like almost to look for, like I said, screening. And so I think a lot of times people will go, and the other thing that happens is people go and then they call their doctor and say, I got an abnormal result. And they have to say, okay, because the problem is they're not always understanding what they are testing themselves for. And they may be testing to check to see if they have one of the, what they call the BRCA genes for breast cancer. First of all, they only test the most common, again, variations. There are many more genes that can increase your risk for breast cancer that aren't on there.
Okay.
And so people say, well, I was negative for the BRCA genes. Okay, you were negative for those common variations, but we didn't do a deep dive and check all of them. And we didn't check the other genes. So that's why I worry that when people do that. Vicky, you have a question.
Yeah, I have a two-part question. So if you go to speak with your family doctor about a concern, I put hemophilia in there because I have a personal experience with that with my child and my brother. But when my son was born, we knew that the oldest one had nothing, and then my second child ended up having it. And when we went to talk proactively about that, now this was in 1994. So, but clear throughout his whole life. He's 29 now. Most people look at you like you have horns coming out of your head when you mention those and von Willebrand's disease. He was diagnosed with both. Like 10 years later, the second diagnosis came. And so I guess my question is just, if you're going to primary care and they have absolutely no idea what you're talking about, do you have any just quick advice that, we can get them to take it a little more serious? And then the second question that I had is from the genetic standpoint. As I mentioned, they were 10 years later diagnosed with hemophilia and von Willebrand's. And now just 2 years ago, both my brother, who's 55, and my son, who's 29, were both told now their von Willebrand's factors are normal and they're only getting medicated. They're only getting treatment now for hemophilia. So I'm kind of confused how that could flip. Do you think it has to do with the testing being different now for both of them to happen?
I do think that as time progresses, we get much better at testing and clearer answers. And I think, you guys may remember the Human Genome Project. That was a huge deal.
Yes.
And until we had that, we kind of had a general idea where genes were, but we didn't know how to test. And every day we get more clarity. So sometimes things are diagnosed as best as we can at that moment, but we get more clarity. It's kind of like taking a microscope and getting tighter and tighter in and using a stronger lens. So I think we're able to do a better job of making a better diagnosis now than we ever used to be able to. And sometimes things looked one way, but when we did a little more, after you get more data, you realize, well, actually, that's not the proper diagnosis. Because when you have a gene change, and I know someone brought it up in the chat about having like a piece of a chromosome additional, right? Sometimes that can be the first person that is ever noticed with that. So then they're like, well, we're not sure what to expect. We can guesstimate based on what we think is there. Same thing happens with a gene change. If there's just a change, we'll say, well, what is that person happening? Does anyone else have that? What are they having? And try to look for the commonalities. So, because they're, bleeding and clotting disorders, and oftentimes there is a lot of overlap.
Yeah.
Sometimes it can be misconstrued for one for the other. And so I don't think it's like it's suddenly resolved. I think they finally just are able to better categorize your family members as to what they have. The other thing, when you're asking about, getting the primary care to take it seriously, family planning is a great reason why you need to see genetics. So both your son, for your son, especially given his age, if he wants to have kids, he
That's
needs
why
to be able to
that's-
say, I am very concerned about passing this on. I know this is due to a gene change and I need to understand that. And I need to go to a genetic specialist.
So
It's
if,
pretty simple. And that's oftentimes that a lot of people end up knowing about genetics because of prenatal
yeah.
situations.
Now, since that was passed on to by me from my X chromosome,
Mm-hmm.
and now they're both being told there's no longer von Willebrands, and hemophilia can't be passed male to male. Does that
No,
stop
but it can be passed male to female. I mean, his children
pass it to
then
a female
will
as a carrier,
they'll all be carriers. Do you know what I'm saying?
but not to
So
a male?
no, unless his partner is a carrier, just like you were, and you didn't know.
Okay.
And you know what I mean? And then you could have impacted females
Yeah.
because both X's. So again, this is why it's so important when we have these things in families that you say, I know this is a genetic thing. I need to see someone who is well versed in genetics that can guide me. And I'm not saying, look, there are some great primary carers who really have taken the time to understand about genetics, but they have a lot on their plates, a lot they have to know about. And sometimes, especially the older ones who, went to medical school years ago, what they knew about genetics then and what we know about genetics now is different. And even those who graduate today will tell you they do not get a lot of genetics in medical school. They get a very finite amount, maybe a couple of classes, not an entire course load, a class or two, a lecture or two. So some get more. We're pushing to try to get, more genetics training because it's so impactful on, health. And that's one of our big goal in West Virginia is to educate providers and other allied healthcare professionals and just the general public about why genetics is so important and why understanding your genetics can be empowering. So I hope that answers your question and any other concerns we have in the chat. Our goal is to have you understand that, genetics doesn't have to be overwhelming. I think Alissa does a great job of breaking down genetics with the genetic recipe, and that just realizing that these changes that we have no control over, naturally occurring, they just happen, but they can have an implication in our health. And it can affect not only us, but it can affect our children. So it's really important, to kind of be aware of them. Leslie, I'm sorry.
Yeah, I was just gonna ask, I know that we're a little bit over, and so is there a place in your website that you would send us to? I know on the other side of the spectrum are people who are very hesitant to get into the mix of looking at their genetics, wondering what that information, what's done with that information and things of that sort. So I just wanted to bring that up so that we could address it directly. And then if there's any section of the website that you'd want to send us to.
Well, yeah, I mean, there is, I'm trying to see if I can open up if you give me a second, maybe I can share my screen back and I can just show you what the website looks like. Is that okay?
Oh, of course. Yep.
Yeah, so I'm going to share my screen again. I think I have it open here. You'll let me know if you can see it properly because I told you are you seeing the NYMAC webpage?
Yes.
Okay, so if you go here and you see this here, you click here and you go to resources, there's a whole section on patients and families where you can learn about all different details, basic genetics, family history, newborn screening, getting a diagnosis. So there's lots of information here. If you have a question and want to reach us, there's NYMAC at FERRA, FERRE.org. And I will also just show you go back here to this menu and you go to our region and you go to West Virginia. Here are stuff about West Virginia, how to find genetics clinics, and a little more about what to expect at an appointment, what happens, right? And the thing I would like to show you is here resources. We have resources for families and providers and also for families with genetic conditions. So there's more information down here that you can use. Here's the Learn the Signs, Act Early that I talked to you about, developmental milestones, Birth to 3 is a great one. So there's lots of information here on our website. And so I encourage you to take a look, and I'll also really quickly put my email in the chat in case you have questions. And yeah, so and I said too, if you found this interesting, our virtual conference is coming up. It's free, April 18th and 19th. And you come and see if you want to learn more or have some questions and hear from other folks who are going through similar journeys. So I'm really quickly putting my email in the chat. It's actually pretty easy, rnsao@gmail.com, but you can also use the NYMAC one. And or you can reach out to Leslie, and Leslie can reach out to myself, Katie, and Alissa. But thank you so much for this opportunity to talk to you all.
Thank you all for sharing your time with us, and it's been very helpful. And I believe our family to family group has been connected with Melina and her team and the parent network specialist. So we appreciate that collaboration too. So,
Oh, is Melina here? I must thank you, Melina, for making this happen. Melina's the one that thought of you, Leslie, and that this would be a good opportunity to reach you all. So thank you, Melina, for
Thank you. It
making
was
this
great.
happen. Thank you. And thank you all for your time today. Sorry we went a little over, but if there's any follow-up questions you have, please don't hesitate to reach out.
thank you. Everyone have a
Okay.
nice afternoon. Appreciate your time.
Yes. Thank you. Bye.